First, I just want to thank Teresa for having me here, year over year. I feel like getting a little long in the tooth. But this is kind of my favorite place to come, all year. So to see friends and people who are dedicated to this little niche that we are operating in. So I'm so excited. I try to keep up with the science and follow you guys. Not my background, but in a practical way, I hope that we can make some of this science obviously a reality for patients by providing access to these technologies that really can change their lives. So thank you so much for having me. I'm going to try to let another patient speak to this. This is a patient who moved me personally and had an influence on me. She testified in California a few years ago when we had legislation pending. So let's see if we can listen to Victoria.
I was diagnosed with Hodgkin's. I was given less than a week to discuss my options with my husband. And we met with a Kaiser fertility specialist who told us that we needed to begin the process immediately as it would delay my chemotherapy. The catch was that I would need to come up with $15,000 by the next business day, and that wasn't an option for us. We weren't provided any information about insurance coverage for the procedures that I should have received. And to be frank, I've felt ashamed of myself since that day. As a future social worker, I feel that I should have been a better advocate for myself and for my husband. I now have to watch as chemotherapy drugs are pumped into my body, knowing that they're killing my cancer, but they could be destroying my chances of being a mother.
So I just wanted to open with, words from a patient who has been affected by this. She's doing well. She's finished her social work degree, and she's involved in trying to help get coverage. And I think that her testimony was really powerful. So I first want to start with just a little bit of an overview of where we are with regard to mandated fertility preservation coverage in the country, and kind of a little bit on how we got here. So 2016, the landscape looked like this. It was quite blank and wide open, and there were no state laws at that time in effect to mandate insurance coverage for fertility preservation. And then we will speed ahead over the next couple of years to where we are today. So we have seen a lot of progress in the past probably 2.5 years toward mandating coverage. In terms of a summary of what this breaks down as, we have seen introduction of bills in 21 states now in the past few years. 8 states have enacted coverage. California was the most recent. That took effect just on October 12th of this year when the governor signed that bill. And currently for this legislative session, there are 2 bills that are still pending, one in Massachusetts and one in New Jersey. So this is kind of what it looks like in a table. These are the 8 states, and I don't expect anyone to read this, but I can send anyone these charts if you want. I think the really important thing to know is, each of these states has done this a little bit differently, and different populations of patients are covered. So this isn't like the end-all and be-all. It's not going to get to everyone. Certain insurance providers are covered, certain are left out, so there's still more work to be done. But I think importantly, almost 30 million people now in the United States have coverage who did not have that coverage 2.5 years ago, and can access these services. So I just want to touch upon, now that we're starting to accrue some successes, if I can be so bold to say that, we have the benefit, now to be able to look back and think about what are the commonalities. Why have bills succeeded in certain states and failed in others? And so we've tried to kind of drill down on that so that we can replicate those successes to the extent possible. I had to put a little plug in here for Kristen Smith, and when we got to be with the governor who signed that bill, and that was a great ceremony, Teresa, here. So I think what we have sort of taken away at this point when we look at this is that in terms of the structure of the bills that have succeeded, we have seen that they either are infertility bills that would include coverage for IVF, and fertility preservation is built in as a part of that, or we've seen fertility preservation bills alone but those have occurred as iatrogenic infertility coverages. So in many states, we have seen people introduce bills that have different language about only covering cancer patients, language with very specific populations like only 18 to 40, and none of those bills have succeeded. So the broader bills to provide fertility preservation for anyone who needs it in this medical situation are the ones that have succeeded. In terms of the coverage environment, what is already in place in a state, many of the states where there was a fertility preservation only bill, it was introduced in states that have already addressed these issues and have already made a policy decision to cover infertility treatment. So that makes that ask a lot smaller, and it's an environment that lends itself to adding on this coverage. And a few states lately, which has been exciting, have actually done everything all at once. So in Delaware, for example, New York's a little different because it went through the budget process, but Delaware and New Hampshire actually went for the whole package of, infertility coverage up to and including IVF and fertility preservation. So in every state, except the one that I'll get to in a minute, California, there has already been an insurance mandate in place in the state to provide for IVF coverage. In terms of the political environment, I think this is really important, and we have looked, and really the net here is that any really deep red state that is very conservative politically and culturally, we have not seen movement of these bills. We've seen some introductions. We've seen introductions of bills in Kentucky, Louisiana, for example, and they just have not even gotten hearings, and they don't really move. Well, Kentucky had some hearings, but it did not pass, and we don't anticipate that they would pass. The legislative barriers, I would say, in every state have really, there is a lot of commonality. The number one barrier that we come up against are the fiscal concerns about how much this is going to cost. This is the number one talking point of the insurance companies, and they push back against that. And they are concerned about, obviously, increasing their own premiums, and they also try to emphasize to the state that there may be some state liability, and so the legislators obviously aren't happy to hear that. The state concerns really turn on this idea of insurance mandates that go beyond the state essential health benefits plan being something that the state would have to absorb. And so I know that gets very technical, but it's sort of a no-go. So there are some legislators who just automatically say, we just cannot endorse any kind of insurance mandate because it could cost money to the state and we're not going to do it. So that's kind of a difficult challenge to overcome. And we've seen some opposition from small businesses who would have to provide this insurance, just for cost. We have also encountered some religious or cultural opposition to these bills, really based on kind of right to life issues, concerns about creation of embryos. Some states will have had simultaneously, fertility preservation coverage legislation, and also have personhood bills pending. So that's going to be a challenge. I think there also persists this idea about who gets infertility treatment and what population that is serving, and so sometimes that can be a little bit of a political hot potato. I think what's been most challenging for me personally, I'll tell you, is each time we enter into a new state or look at, having a bill run in a new state, there are really particular processes that are in place. There are all kinds of deadlines. Every legislative session is different. There are politicians who really are the gatekeepers and hold control, and so you have to kind of learn about those relationships, or if you have this bill sponsor, then you start to understand, well, then this committee chair will not introduce that person's bill. So there's a lot of kind of behind the scenes information that it's hard to get, other than really being there on the ground. And sometimes that has led to the need to have lobbyists who really can negotiate all of that. So I think, importantly, we should look at how we achieve coverage on a go-forward basis. First, I just want to say this is something that we've thought about now for many years, and I think was first presented here, not by me, to start to think about fertility preservation coverage, and it is a little bit of a hybrid. So we really sometimes talk about fertility preservation as iatrogenic infertility, as a subset of infertility. And in some places, that's going to be an effective talking point and an effective strategy for moving forward. I think that there's also another way to look at fertility preservation, and that's more as a part of cancer care and cancer coverage that it should be included under. So the left-hand arrow, I think, really puts us on this continuum of infertility coverage that I was talking about, and we've seen some traction in blue states toward better coverage for infertility treatment itself. So in some of those places, we don't even have to start with fertility preservation only bills, which is, as I said, really based on iatrogenic infertility and being a subset and a really small population. So when we get that coverage achieved, we're only getting fertility preservation for cancer patients. We're not getting any sort of post-treatment coverage, right, that patients may need. I think where it's possible, we've tried to work together with other infertility organizations across the country, principally Resolve and ASRM, to try to get the whole package of IVF coverage as well as fertility preservation, excuse me. And I think, honestly, there's some thought, and in some states we've actually started to see some introduction of elective egg freezing and even more comprehensive coverages, which I think, honestly, is the fear of the insurers, that this is where we're going with this coverage. I think where that avenue is foreclosed for whatever reason, it's important to think about and discuss fertility preservation, as I said, as seated kind of in cancer treatment itself, or whatever disease it is, or whatever condition it is that you're looking to cover. I think obviously cancer treatment is medically necessary, it's life-saving, that's covered, right? Those, I mean, typically, mostly, whatever you need for your actual treatment will be covered. Fertility preservation coverage is what we try to argue when we're looking at this kind of coverage or this path to coverage, is that this is also medically necessary, right? Patients have no option. This is not some sort of elective procedure if someone is facing potential sterilization. It's needed to minimize the harm. It also, you can make arguments that it helps people adhere to treatment, and we've seen especially papers published in the breast cancer space that talk about that. We think there are equity points to be made about fertility preservation options as akin to treating other side effects that would normally be covered. And so we think that there's a fairness argument there. And in terms of just increasing patients' quality of life, reducing distress and depression, and sometimes those benefits can also have some financial implications, right? If someone has to seek mental health services or they don't adhere to treatment, there are also potentially some financial downsides to that. And this model that we're looking at now is really like the WICRA model, which I'll talk about right now, which I think is really the best kind of analogy that we have. So WICRA is the Women's Health and Cancer Rights Act, and people have published about this before, but this was a federal law, and it really just deemed reconstruction after a mastectomy as something that's medically necessary. And so that had to be part and parcel of what an insurer would cover when they were covering breast cancer treatment. And so I think it's a really good model for us to work with. This law in particular, it occurred and it happened after there had been similar laws in states for this kind of coverage. So there was a patchwork of states that allowed this, and I think the federal government started to look at that and see the unfairness of that and step in, and they were actually able to amend ERISA, which is the law that covers self-insured plans, which is more than 50% of insurance plans in the United States, and those are plans that we cannot reach with state mandates. So that is definitely something that we look at down the road. So I think the best example that we have of something that's a little bit different and a little bit on the WICRA model so far is the coverage that was achieved in California most recently. So California was the first state to have fertility preservation coverage passed and recognized, I should say, where there is not an underlying IVF mandate in the state. So this determination and this bill really passed. It's based on state law that governs the managed healthcare system. And what it says is that insurers have to cover what's deemed basic healthcare services. And they said that fertility preservation falls into that category, okay? That this is a basic healthcare service. Someone cannot opt out of this. They can't forego life-saving treatment. And so it falls under that rubric, which was a really important thing to achieve, I think. The bill itself is a little bit different than other bills in other states because it really sought just to clarify coverage because the state regulator had already made this recognition. So, and we got good press for this, Los Angeles Times, so people picked up on it. It was really important. And that was obviously, in terms of numbers, that hit almost 17 million people. So in one day, you know, to be able to get that coverage was really important. I think that one important lesson we learned with that, and where's Joe Letourneau? He's here, and Christine from UCSF. We worked in the state of California for 2 years, maybe more, to try to work with the regulator, the insurance regulator, to achieve this, because we had been told by the then governor's office that a mandate for fertility preservation would not be passed. It would be vetoed. It was vetoed in 2013. It would be vetoed again, and that we needed to find another path. And so we started to have meetings with the regulator. We tried to understand the regulator's appeal process within the state and work to identify patients who had really, you know, typical cases, really, and submit those cases which had been denied coverage through the appeals process to get independent medical reviews. And I think there must be 20-something now within the system, and they're still going on, frankly. But what we saw was anytime these cases were reviewed independently by independent physicians, they, of course, came to the conclusion that the insurer should have covered this and that this was a basic healthcare service. These services are now standard of care. They would cite to the guidelines, ASRM and ASCO guidelines, and they would order the insurers to reimburse the patients. So I think that having that background, having those decisions in print to share in meetings with legislators at hearings and be able to discuss that result was really important and helped to undergird the legislation. So I think that that is a good mechanism to start to flush out this coverage. This is just an example, and I've shown this before, but I mean, each of these came out, and there is a website if anyone's interested, and you can go and you can read them, and they're all the same. And they really just say that the reviewer determined that these services were medically necessary and the insurer should pay for them. So I just want to quickly also touch on policy arguments for coverage, and I have different presentations where we break down each of these, and if anybody's interested, we can get into a lot of detail and look at articles that support these arguments. But I think regardless of the path that you are looking at, all of these arguments are applicable, right? So I think it's always important to be very clear that fertility preservation is something that's medically necessary for these patients, for populations of patients who are at risk. These treatments are now accepted as part of the standard of care. This is something that needs to be offered and discussed with all patients, and if they can't access them, then that isn't really a real option. I think there's some indication that this can promote better medical outcomes that I was alluding to, studies that show better adherence to things like tamoxifen and even acceptance sometimes of more gonadotoxic treatment if this fear of infertility is alleviated. I think that the overall cost is very low. So in the scheme of cancer care, in the scheme of treatment, the actual costs are quite low, and there are these potential cost offsets that I mentioned, and so I think it's kind of a difficult thing to say, but I mean, when someone has a better medical outcome, the insurer, if someone, has a relapse or something, and because they're not really adhering to treatment, the insurers will pay for that. So I think sometimes in those discussions with them, you have to be frank about that as something that you're trying to avoid. And I think we saw most recently, I would say in New Hampshire, for instance, there are business cases to be made about, implementing these kinds of benefits, having your state be a leader, be a healthcare leader, and attract, young populations of people who are concerned about being able to have children. And I think that something that we're just getting to and looking at are now a lot of equity considerations around this. Who, even when we get a mandate, who does that cover, and who gets access, to these treatments, and who is still getting left out, and how we're going to approach that. So I don't know how I'm doing on time. So in terms of next year, as we're gearing up and we're getting ready to see where we're going to be working, there is definitely going to be legislation pending in a few states, in Arizona, in Colorado, and in Washington. They all have evinced interest in putting forward bills, and Massachusetts and New Jersey, those bills will continue to be pending if they haven't passed by the end of the year. There are active state coalitions right now in several states where people are pulling together, and we're going to talk about this at lunch more, and the activities that you can do and how you can kind of push this work forward even if you're not ready to introduce a bill. And so there's a lot of activity going on that will be going on this year, I know, in Iowa, Oregon, Texas, Utah, and I hope I'm not leaving other people out. I mean, we've had a lot of emails from people even in, I know there's interest in Ohio, Pennsylvania, Minnesota. So there's a lot of activity and a lot of interest in getting involved with this. I think the next level, now that we're getting some of these bills passed, is to start to look at the implementation of these bills. I know, where's Kara? Kara presented on that, mystery shopper at ASRM, calling clinics to see what they know. And, there are major disconnects out there, and we're still seeing it in California. This week, there were 2 patients that we know of who, were turned down for coverage. And then we have to, have the physicians' offices sending over the bill. The bill was signed, and you're on the hook. So there are definitely gaps in how the bills get implemented. And as I said, then we have to look at really which populations are not covered regardless, even if they're being implemented correctly. One of those areas, obviously, is Medicaid, and I think that's a challenge. And I know that there are people in this room who are interested in that, and we're looking at having a Medicaid task force and trying to figure out how we can approach that coverage, and eventually, hopefully, also federal coverage that will then get all of the plans that the state legislation cannot pick up. So that's looking ahead. Thank you.